So welcome to our most recent What's Out There online session on shoulder health. I'll hand over to Nazim Erdem, our panel chair, shortly to introduce the rest of the panel. But before we begin, I'd like to begin by acknowledging the traditional custodians of the land on which we meet across various parts of our state and possibly the country. I'd like to pay respects to these people, their culture and their traditions. And I'd like to pay particular respect to their elders, past, present and emerging, and any First Nations people that are joining us today. So without further ado, I'll hand over to Nazim Erdem, our panel chair, to kick off the session.
Thanks very much, Sal. So thanks everyone out there who's watching. Later after this session, what we're going to do, if people want to come face to face and ask some questions, they're welcome to do that. But you've also got options as part of the Zoom meeting where you can raise your hand to ask a question or send a question in the chat function there as well. I want to welcome Janet McCarthy from Austin Health, Emily, Geoff, we've got Alex, Lynne Panayiotis, and Duke's going to be joining us as well in a couple of minutes. I thought might be best to start with pretty much an introduction of ourselves. So if we go around, Janet, do you just want to introduce yourself and quickly just talk about your role at Austin Health?
Yes, certainly. So my name's Janet McCarthy. I'm a physiotherapist, part of the Victorian Spinal Cord Service. Some of you will probably know me over the years. I've been there for quite a while now. So my current role is as a spinal outpatient physiotherapist. So shoulders is a fair bit of the work I do with people. I guess help people through and working with challenges of shoulder pain and having a look at their environment and all the things from a spinal side of things that have an impact on your shoulders.
Thanks, Janet. If we move on to Emily. Emily, quick introduction about yourself, when you had your injury and what your injury is.
Hi, I'm Emily and I have a T4 spinal cord injury and I was injured in mid-2018.
Thanks, Emily. And over to you, Geoff.
Hi there, I'm Geoff Dossetor. I've been C4-5 quad since 2001. When I had a hang gliding accident, and yeah, shoulders aren't great, but I try to maintain them as best I can, and that's all my expertise really. Yeah,
no, thanks, Geoff. Over to you, Alex.
My name is Alex Herrera. I'm para from CT. T11, 12, 1L2. I've been paraplegic since 1984. So yeah, a long time. So I have started having shoulders problem about 10 years ago or more. And then I seek, doctors advice what to do, and then I started having cortisone injection to mask or the pain, and then I went to a waiting list for surgery at the Austin. Yeah, so and then,
thanks, Alex, and we're going to talk more about your shoulder injuries and sort of how you've dealt with them over the years. So that's going to be really good for people to hear. Lynne, can we have an introduction from you, please?
Hi, everyone. My name's Lynne. I work at the Austin as the peer support worker. I'm T12 from a bus accident back in 2006.
Thanks, Lynne. And Duke, who has just joined us as well, he's actually come from a bit of sports training. Duke, just quickly, a bit of a rundown on yourself, please.
Hi, my name's Duke Trench-Thiedeman. I'm a 68-year-old person who's presently got a shoulder rotator cuff injury. I play a lot of sport. I've been playing sport for nearly 7 years now, and I had a motorcycle accident in 2009. I'm a paraplegic at T10 with titanium rods in my back between T10, 11, and 12, and I'm in a wheelchair and require my arms to transfer and all those other things.
Excellent. Thanks, Duke. And just on myself, I had a diving accident. I've got a C6 complete injury way back in 1991. I've been pretty active since, and have sort of, as most of us will have, had issues with my shoulder. Thanks everyone. Just wanted to go back to Jenna, who's going to give us a quick presentation on shoulder health. And I just want to add a bit of a disclaimer before this. I mean, what we're going to be discussing is just general information about how to maintain our shoulders after a spinal cord injury. A lot of us will have individual and specific shoulder injuries that we have, and each one is different. Just like a spinal cord injury, shoulder issues are pretty much the same. So, hopefully we're going to provide you with general information, and if you want more specific stuff, in particular about your own issues, it's really important to go through the proper channels, and that's, seeing a doctor and physio and all those other experts out there. So, Jenna, over to you.
Yes, so I was just going to start with a little bit of an introduction about the shoulders and having a little bit of the anatomy, and then perhaps if we, for some of the other stuff, we can probably sort of get information from the rest of the panel and come back to, I can provide a bit more information on some of the other bits on the way through. So I'll just start with a little bit of a introduction. Just bear with me while I attempt to share a screen. Okay. Excellent. So I guess I just wanted to start with saying, shoulders are an amazing joint. They're really quite phenomenal when you think about it. Your shoulders, if you think, what is the purpose of your shoulder? Essentially, your shoulder is a really, really mobile joint that allows you to get your hand in. If you think about the amount of different places in space that you can get your hand, it is pretty phenomenal, really. So the main purposes of your shoulder are for pushing, pulling, throwing, carrying, placing an object, and being able to manipulate things in your hand or move things about. Obviously, through evolution, we have started out being on arms and legs, and then have evolved into being more upright and having our arms as not being a weight-bearing joint anymore. The challenge, obviously, for most of you after you've had a spinal cord injury is your arms and your upper limbs become a weight-bearing joint again. So the process that has happened over years, adjusting how our shoulders and our arms work, have gone back a bit in terms of the how we use our shoulders. So I just wanted to run through quickly what some of the parts of the shoulders are. So quite unbelievably, your entire arm is held on by your sternoclavicular joint. The whole arm, that's the only joint that it attaches to your body. Okay, you then have your clavicle here. Can you see me moving my cursor on the screen? Yep. Okay, so your clavicle coming out to here. This is your shoulder blade at the back here. Okay, so you've got a joint there at the end of your clavicle or your collarbone that it is commonly called. And then you've got your main shoulder joint here, which is the glenohumeral joint. Now, the glenohumeral joint is a really, really mobile joint. It has a very, very small surface on one side, which is a little bit like a golf tee, and then a golf ball on top. So it's not a particularly stable joint, but that is because we are needing it for so much mobility. Some of the other components of how our arm works is your shoulder blade rotates up and down to give you your range of movement, and helps in all your range within space. You've got a lot of muscles that help provide some of the structure and the stability in your shoulder. So I'm just going to move over to the next slide. So in regard to your rotator cuff, which most of you will have heard of, and particularly those of you who have had trouble with it in the past. So your rotator cuff is made up of four different muscles, and your rotator cuff muscles only go from your shoulder blade to over your shoulder joint, and their main role is to help keep your shoulder joint nice and stable, and help it spin and move nice and neatly and efficiently. So because your shoulder is so mobile, it relies on some of your, the timing and the strength and control within your rotator cuff to keep it moving and to keep it strong. So your rotator cuff is really, really important in terms of controlling that head. Where we run into some troubles when we've got weight bearing through your arms is there's a lot of pressure up through the top of that joint, and that's where your rotator cuff really comes in, having good control and good strength to make sure that is working nice and efficiently. So the health and care of your shoulder does very much depend on having good control and strength in your rotator cuff muscles. You also have quite a few muscles that work on the shoulder from a distance. So you'll see in this picture here, you've got quite a few muscles that work onto your shoulder blade that come off your spine, and also ones that come off on your neck. So your neck and your shoulder are very, they work together, and things that are going on for your head and neck are going to affect what's going on in your shoulder as well. We've also got quite a few muscles that are coming from your trunk also onto your shoulder as well. So when we're looking at shoulders, and if you're having problems with your shoulders, we don't need to just look at your shoulder joint. We do need to look at other areas of your shoulder, and that's very important. Some of the muscles that I was just talking about there that we need to consider are your traps. So you've got your upper, middle and lower traps, your rhomboids and levator scap here. So the reason I've got this picture here is one of the problems that we run into a little bit with when you've got a weight-bearing shoulder is all of the tasks that you do result in your shoulders being rotated down or forwards. I'm sure all of you are probably reasonably familiar with this. If you are a wheelchair user, you're pushing the chair, you're transferring, all of these things are tending to rotate the muscles that you're using are rotating your shoulders down and forwards. And that can create some problems in terms of balance around your shoulder joint. When you're using one set of muscles much more than the other, then you get an imbalance, and we often need to work on working stuff back the other way. So one of the things that can commonly happen is you get a bit stuck down, and when you're going to reach and you start doing things overhead, that can create some problems there. I will also say here, for those of you who are walking and using gait aids, that we run into some similar things when you're using walking aids and things like that as well. A really, really important muscle within all of this is one called serratus anterior. It's the one that helps keep your shoulder blades on your chest wall, and there will be some of you that don't have great strength in that because you might have a higher level injury, and it's a really important one for keeping the muscles on your shoulder blades on your chest wall, and also for being able to rotate your shoulder blades up. So that's often one that we need to have a little bit of a look at. Okay, so I'm just going to come out of this here now and come back to here. So some of the challenges that happen for shoulders after a spinal cord injury, as I said, some of you will have what we call fully intact shoulders, in terms that you have all of the muscles working around your shoulder and your upper limb. There'll be others of you that have got some of them working. Some of them might be absent. Some of them might have a little bit of strength, but not being able to do everything against gravity. One of the other challenges is not necessarily also just whether you've got all the muscles working around your shoulder, it's the fact also if you haven't got all of your muscles in your trunk as well. So in the general population, shoulder problems are actually really quite common as well. And, you know, everyday people run into shoulder problems as well, even when they're not using a wheelchair. And that is probably the third most common problem after sort of backs and knees in terms of in the general population. What we do know is that if you do exercises and have a look at those type of things, that you are able to make an impact and manage your shoulder pain within that. One of the challenges when you don't have all the strength in your trunk is it means that your shoulders take some of that load as well. So normally if you were doing something with your arm before your injury, you would have been using your trunk to help with some of that movement. So that can increase the load on your shoulders. And it's also, if you have got some trunk movement, and you're having shoulder problems, that it is important to have a look and make the most out of that as well. So obviously, if you are using your arms a lot, using them in transfers, pushing the wheelchair and all that, one of the issues obviously is overuse. And how much you're doing that. That can also become a challenge when it's your only way of exercising as well. So it's about finding a bit of a balance between how much you're doing within that. I might leave it at that for the moment, and we can come back and talk about some of the other bits interspersed.
Excellent, Janet. I mean, you sort of see the rotator cuff, you know, it's pretty complicated, and you know, when we use a wheelchair, you know, the shoulders aren't designed to push a chair constantly, you know. Your legs are meant to be your mobility, but when you lose that, you have to rely on your shoulders. And yeah, the shoulders actually like just get a lot of pressure on them. Not only that, but your posture as well. I sort of noticed that people that have been in a chair for quite a while, because you're pushing your chair, propelling forwards all the time, your shoulders actually curve forward a little bit. And I don't know what people do to prevent that. It's really important to, you know, try to sit straight and keep your shoulders back as much as you can. I think that would help in prevention, but just wanted to hear from the panel as well if anyone has had shoulder issues along the time. And you mentioned, Janet, a lot of people in the general community, you know, they don't have to have a spinal cord injury. Lots of people have shoulder injuries that they aren't even aware of. Can I just throw it out there, if anyone has like had shoulder injuries that they've been managing for a while?
Yep.
Duke?
I'm very fortunate to have had Janet to resolve my. I had a right arm shoulder injury probably about a year ago, Janet.
Yeah, probably.
and we were talking via Zoom and trying to connect up and do things. Mine was really, and now I've got one on my left shoulder, and I put that down to not doing going to the gym or playing any sport for a year. And I think a lot of us will be in that same boat where we haven't been able to get out, and all of a sudden we're stressing our arms in doing extra things besides the normal moving around the community as far as transferring and things like that. And so I'm at the moment getting remedial stuff done for my left shoulder. So it's all to do with keeping things moving, and unfortunately being in a wheelchair, and I play wheelchair sports, it's the pressure of pushing your wheelchair as well as holding a racket at a strange angle.
Thanks, Duke. Lynne?
I dislocated my shoulder a few years into having a spinal cord injury, and as a result ended up with a frozen shoulder. And I went in and saw the physio and a surgeon at the Austin, and wasn't able to do one of the particular exercises that they recommended for me. So they were starting to talk about surgery, but they gave me a 3 or 4 week period, and I was very fortunate to have this amazing physio in the community. And so I would say they did the exercise and I went, oh yeah, I can feel the stretch. And that was the one I had to try and replicate. So that's what I told the physio. I happened to be in the water, and so she said, try this. And I thought, no, that didn't do it. She said, okay, thought about it, try that. No, that didn't do it. Third attempt, I went, oh yeah, that certainly gave me the stretch that they were after. And within that time period, got full mobility back, didn't need to have surgery. Surgeon was amazed, had never seen it before. But I think having a physio who's can think laterally to be able to come up with different ways to doing the exercises that you need to do to be able to maintain that flexibility and strength.
Was her name Janet?
No, it wasn't.
No, but I have seen Janet for my other shoulder many years later.
Yeah. I don't know whether it's helpful for me to talk about the process that I normally go through when people come in to see me with shoulder pain, in terms of what are some of the things that we look at, so that people can have a bit of an idea of the overview of things to think about, I guess, from that point of view.
Oh, I think definitely, Janet. I think people would be interested in, okay, if they do have issues, well, what is the process and what does it mean? And when they're working with a physio, what sort of things do they sort of need to be aware of?
So as I mentioned before, probably the biggest thing that we run into problems with is, number one, the overuse side of things. Usually people are coming in to see me because they've got an episode of shoulder pain, or they've had shoulder pain for quite a period of time. Now, by far and wide, the majority of people have got what's called rotator cuff related pain. Okay, so shoulder pain gets categorized into a certain number of things, and the most common thing that happens in wheelchair users, and as I mentioned before, this still happens in people who are using walking aids and in the normal population as well. It's far more common presentation than what Lynne was talking about before in terms of a frozen shoulder. And the things that predispose you to that are usually, sorry, did you say something? No? Is usually a change in load. Now, what I mean by that is you have done something that you haven't done recently, essentially. So tendons, so our shoulder is made up of a whole heap of muscles and tendons that need to work in some, you know, pretty good timing and strength to be able to keep everything moving very well, because we've got, I might just pull that picture back up again, just bear with me. Oh, sorry, I need to come out of this. Go back to sharing. So what makes the shoulder really tricky is this little bit here. There's a not very big gap between your acromion and the top of your shoulder. So your rotator cuff, as you take your arm up, your shoulder blade needs to move and your arm needs to rotate such that as you bring your arm up in the air, that it avoids hitting the top of that. Okay, and you've got a whole heap of tendons as well that run underneath the part of your rotator cuff that runs underneath. So if you're lacking in range, if your rotator cuff is weak and a range of other things, you can get some squishing happening in that area. And when that squishing happens repetitively over time, it can you know, can set up some irritation in that area. Now, what makes you prone to doing that is, so the tendons off of these here, tendons don't like change. Basically, you know, they like to do the same thing day in and day out. So if you have not done something in the last 4 weeks, you haven't done it. Okay, I think that's probably, I try to use that as the best guidance for people to assess what's changed. Okay, so what if I haven't, like Duke was saying before, if you haven't been doing as much activity because of COVID and what's happened in the last year, and all of a sudden you go out and do stuff because you haven't done it recently, you've had a big change in that load, and that can be what can set up some irritation in that area. So the vast majority of times, rotator cuff related pain can be traced back to something that has changed in what you have done recently. Now that might be you just started doing more, or it might be you've been a bit sick so you haven't been doing as much, etc. So that tends to be usually it's a matter of going through and having a think about what's changed. It could be you went out pushing and you were doing a lot of pushing on a slope and one arm was getting a lot more work than the other. And there's going to be times that your body can cope with those changes, and there's going to be times that it can't in that regard. So when people come in, usually I'm going through a process of finding out, you know, what the symptoms are and what has changed recently. We also then have a really thorough look at what your range is, what your strength is, and how you're moving. And the other thing we look at is, as Naz was talking about, we have a look at your posture, we have a look at your how you're pushing your wheelchair, because that, and how your wheelchair is set up, because some of those things can have an impact on that. And we look at your transfers and your technique, how you're moving in bed, what your equipment is that you're using, and having a big overall look at what is going on, so that we can put together a plan to be able to manage that, because the majority of the time what we're needing to do is to manage how much load is on your shoulder. If you've got pain, we need to decrease the load to a point that your pain is improving, and then gradually increase that back up again. And that will involve exercises, but it also involve looking at equipment and how you're doing things. I don't know if that helps, but yes.
No, definitely, Janet. Thanks for that. That was some great information.
Janet, one of the things about having an injury is being able to rate a change of what's happening. So one of the things what happened to me is to know there was a starting point with the injury, if you like to call it that, and the progression through the remediation on that. And so that was quite important for people to ascertain as to whether you were improving or you were static in your improvements. Is that of any aid to talk to people about that thing as far as that goes, Janet?
Usually one of the assessments that I use when people come see me is I use a rating scale, which is called the Wheelchair Users Shoulder Pain Index. It's a series of 15 questions where you rate from 0 to 10 on what pain you're experiencing during those activities. One of the most important ones that we always want to get down is if you've got pain at night, okay, because pain at night is usually indicative that there's a fair bit of inflammation in the system, and that's the bit we want to manage first. But I find that a very useful thing to have a look at in terms of even pinpointing what activities, you know, if you've got a pain that's happening during activity, what activities is it that pain is occurring with, because that helps. And you can use that to remeasure obviously how you're going as well in terms of how you're rating your pain.
I suppose what I was asking then is, should you see a professional about an assessment so that they've got some, I don't know, some starting and some point at which they can say, well, okay, this is what you're like a month ago or something like that. So I think it's very important to get it assessed by a professional in some form.
Yes, I think that if you've got pain that's not just, oh, I know I did a fair bit yesterday, I know I've used my muscles, you know, if you've actually got shoulder pain, and particularly if you've had shoulder pain that has reoccurred, then I think, yes, definitely you need to be making sure you're getting that assessed, because very, very likely there's plenty that we can do about it, and in terms of managing that. And I think you also learn each time as well, you know, a bit more about your body and what to do in terms of managing that. I think also to take heart in terms of rotator cuff, I guess the evidence around management of rotator cuff injuries in the general population, particularly, is that physiotherapy exercises are as effective as surgery in the vast majority of cases. And I think that's a very important information to think about, because surgery is such a big thing to do if you're a wheelchair user, and the implications. I know there's people on the panel here that will be able to talk to some of their experiences with that.
Great, thanks for that. I just wanted to go around. I mean, we're talking about pushing our chairs, and you know that causes a lot of our pain issues that we do have. But it doesn't matter what level of injury you've got. Even if you use a power chair, for example, I mean, you still can. You know, shoulder health is something we need to be aware of. I just wanted to throw over to Geoff. Geoff, can you speak to us a little bit about, you know, how you maintain your shoulders? You know, not just the shoulder health in preventing injuries or anything like that, but just keeping it healthy. What sort of things do you do as a habit to, you know, make sure your shoulders are fine-tuned, I guess?
Okay. In the early days, I did a lot of different kinds of therapy, and I found that I wasn't really changing a great deal. So I got a bit lazy, and I sort of got down to basic routines that I try to keep up every day or every week, that sort of maintain my shoulders so that they don't get any worse than what they are. A lot of the musculature around the shoulder joint has sort of wasted away since 2001, and so it can be a bit bony around the shoulders. So I have to be careful when I sleep at night, because I tend to sleep on one side or the other. I alternate each night, and if I have my shoulders, too far onto if I roll too far onto a shoulder joint, I can get a pressure area develop around the bony prominences, and so I have to be really careful when I roll onto my side. I have to ask my carers to twist my shoulders back the other way so that I don't put a lot of pressure on the bony prominences. And I can't feel it at first, whether I'm on it or not, but after a few hours of lying on a bony spot, I will get quite sore. So I have to be careful of that. And in the morning, my shoulders can be a bit stiff. So I always ask my carers to do stretches in the morning, and pretty basic stretches, just keeping my arm pretty much in front of me, arm and wrist, elbow and wrist straight, and just raising my arm up and down, about 20 times on each shoulder, and that usually loosens them up a bit. And usually 3 times a week, I have hand splints on to hold my wrists out straight, but I've got an older pair of hand splints that I've just rigged up a little loop on the point of the hand splint, and I hook that over the handle of an arm cycle. It's called a Saratoga cycle, and I don't actually power the machine on. It does have a resistance setting, which if I was stronger, I'd probably use, but I just have it powered off and freewheeling, and I just go for about half an hour. I usually cycle with my arms cycling forwards for 5 minutes, and then I flip it and go the other way for 5 minutes, and I'll do that until I get up to half an hour, and it doesn't really tire me out a great deal, but I find it good just to maintain what strength I've got in my shoulders, and it also stops me from getting a lot of soreness in the shoulders. And the only other thing I can think of that I can mention is that I find sometimes with shoulder strength, I don't know if it's psychological, but sometimes I feel really weak, especially in my weaker arm. My right arm is the weaker one, and I deliberately changed the joystick on my wheelchair to the right side because that side was so weak. I found that just using the joystick with my weaker arm helps maintain the strength on that side, and I could probably drive the chair a lot better with my left arm, but then I think this one would deteriorate. So, but sometimes, especially if I've been sitting at the computer for a long time, I go to put my arm up onto the joystick and I have real problem lifting it up, and there's no real reason for it. I shouldn't be tired, but I think, if you're in a bad frame of mind, it can affect the way that the messages get out to the muscles. I don't know. It's a bit of a mystery.
That's a good point, Geoff. We get dependent on our stronger side, and it's good to be aware of that too, and make sure we're using the other side as well, because if you're dependent on your better side, for example, then that side would get more worn out. There's a possibility of that. You mentioned stretching as well. I think stretching is really important. I just want to throw it over to Emily. It's really important that even if you're not very active or you're not sporty, you know, it's really important to have like a stretching program. And a lot of us will probably do it, not even recognizing it, you know, but we do, well, hopefully we do it as a habit, you know, we're stretching our arms and all that sort of stuff. So Emily, do you do any types of stretching or prevention?
I do stretches, but that's for my spasms. But I don't do enough stretches on my arms, which I should. I need to stretch my pecs. But I do exercises. But I learned because not a few months after I left rehab, I got a partial supraspinatus tear, and I had to change my way of thinking about when I do exercises, because I used to just try and do the heavy weights and try and get as many reps as I can and stuff like that. But I've learned to change the way I do exercises and about keeping everything in alignment, as best alignment as I can, and doing stretches, doing exercises the right way instead of trying to get that strong weight. So I've pay more attention to making sure I'm in alignment. So for example, in transfers, I now try and keep my shoulders back in better position. They're not perfect, but thinking about it, trying it, it helps, I think, and improves it. And even lifting up to do my pressure lifts, so I'll try and keep my shoulders back and in the right place. And I do different things like that to work on prevention. And I also work on keeping my neck back in the right position. And I will try, and I'm T4 injury. So, but I've read in my research online and stuff, having better pelvic alignment makes things better. So makes it easier to align. So in exercises, I have like a wedge that I sit on to make my pelvis in better alignment, because I can't do the pelvic, so I get supports to help it better aligned, and it makes it easier to have my shoulders in the correct position when I'm doing the exercises, and I think that's helped made my shoulders stronger.
No, thanks, Emily. So there you go. I think we do stretches, you know, to prevent shoulder issues, and even with spasm, you know, I mean, it's important that we do stretches with spasm too, but we're not just doing it for spasm as well, you know, it's actually helping with the overall health. Just wanted to throw over to Alex, if I can now. I know, Alex, we haven't talked about your surgery that you've had, but so we'll talk about that a little bit shortly. But regarding stretching over the time that you've been in a chair, have you found important to do regular stretches, even if you're not playing sport or very active?
Well, I live in a little farm, so I'm very busy around here, you know, moving firewood, chopping firewood, using chainsaw, you know, just doing gardening, and so before that I was just working part-time, you know, as an upholsterer, using my arms all the time, driving long hours, and so at the end of the day I was just exhausted, just, you know, resting for the next day. So so I just don't do much exercise. Now I start doing weights in bed. So it's just the use gravity. But on the whole, there's just stretching. It's just I do stretch my arms, you know, when I'm sitting down, putting my arms over my head, you know, and so on. But in the exercises I do it with the physio, I was just doing it every 2 weeks, exercises, you know, shoulders. But yeah, so it's what I do every day.
And that's around maintenance, more maintenance, yeah?
Yeah, it's more keeping myself active, because I go down the driveway, you know, I just want to go down the grass. Keep in mind that I just got a smart drive and now they help me a lot.
We're actually going to talk about that as well, smart drive. So this is something that's become more and more popular over the last 5 or 10 years. And we'll talk about the benefits of that too, because that's really important. Lynne, I just wanted to go over to you now. You were playing basketball. It's really important, you know, you don't have to be an athlete or anything like that to have a stretching routine, you know. I mean, a lot of teams, as we know, regarding like football or basketball or whatever it may be, they actually have part of their game is to have a warm up and warm down. So can you speak to that a little bit, Lynne?
Probably the fact that I was in the team meant I was stretching more regularly, because I find that a team environment motivates me more to do that kind of thing. And I would be happy enough to initiate it if it wasn't happening. So yes, I found that really good, and my shoulders were in really good nick when I did it. I wouldn't mind talking about the experience that I had with Janet. I changed my role and was doing admin here at the Austin for a few years, and over a period of time I was just getting sore and sore and sore, particularly in my neck, and I'd always be quite lopsided, as many of you saying one side is stronger than the other. And so when chatting through with Janet, you know, she always checks you out as she's coming in. I'm pretty sure that's a physio thing. And a lot of it came down to the fact that both my cushion and the canvas underneath it had started to sag, and that I hadn't realised that I should be having that looked at more regularly than I was. So with a series of exercises, some of which I could do in the car on the way to work, which is, you know, I'll pull the keep your shoulders down and pull your head back. Yep. Which I still do. And another one which was, you know, both arms up on the, spread out up on the door frame, and feeling your shoulders being pulled together. And I do that in the shower every morning. Yeah, I find them of great benefit.
Thanks, Lynne. Yeah, the thing I wanted to highlight from that too, even if you're, well, any physical activity that you're doing, even going for push down the street or anything like that, and, you know, getting the chainsaw out like Alex does, it's really important to, you know, get the blood flowing in those shoulders so you don't do any sudden movements which is going to cause damage, because that's what usually happens. It's really important to get the flow, the blood flow going, and the way to do that is just doing some simple stretches, you know, before and afterwards, because it's all about prevention, I think, and we need to be doing a lot more of that. Janet, just wanted to go back to you. You know, we talk about, you know, we've been talking about rotator cuffs and getting tears in the tendons or the rotator cuff. What's the difference between a tear in the muscle and a tear in the rotator cuff, as in the tendon?
So I think, first of all, number one, there depends on where the tear is, and it's not necessarily about the muscle or where it is in the tendon. I think the thing to also know is if I was to scan my shoulders, if we were to go out and scan people's shoulders, you will find tears in people's shoulders. They don't, not all, just because you have a tear on an ultrasound doesn't necessarily mean that you are going to have pain. Okay, so you do have to, yeah, it is generally a scan, and things will show you a deficit in you know, something structural in your shoulder or back or whatever. It doesn't necessarily mean that that is associated with symptoms. Okay, so it needs to match up to what you're experiencing, I guess, is the moral of the story. So just because you've got a tear, I've probably got tears in my shoulders and I don't even know. Having said that, there will be tears that are symptomatic and that are causing you problems as well. Okay, so you can have tears. So if you've got a tendon, you can actually have a tear. It's called full thickness. So it's like a buttonhole that goes through the tendon. Okay, the tendon still is intact. Okay, you can still use your arm. It really does depend on where it is relative to some structural things. And generally, if you can't hold your arm out to the side, then you probably need to go do something about it pretty quickly. Okay, it's pretty common for people to have pain in this kind of range. I'm sure there'll probably be a few of you that are nodding there, but you know, a lot of that is treatable with exercises and managing your load and other bits and pieces. What I would say, just moving on to sorry, does that answer your question, Naz?
It does, but more. Well, I think I was trying to get at, as in repair or recovery. When it comes to muscle tears, that usually recovers because, you know, there's blood flow there. Where it comes to the tendon usually doesn't recover as well as a muscle, only because there's very limited blood flow there, and usually the damage to a tendon is more permanent than to a muscle. I think that's what I was trying to do.
Okay, yeah, it's probably more common that you do their rotator cuff tendon tears, as opposed to it's pretty uncommon to actually tear the muscle in your rotator cuff. In you know, footballers and stuff, that, you know, they might do a tear within a muscle, but that tends to be a bigger muscle that tends to happen in. So just because you have a tear, a rotator cuff tear, doesn't mean you can't get back to pain free. Okay, by, you know, managing what you're doing some exercises and other bits and pieces. Sometimes it's often about changing about how you move and other bits and pieces. One thing I would say, coming back to your stretching, I would probably also say there's a couple of I guess it's more about your range of movement, how much flexibility you've got, because we all tend to sit here and we end up stuck in this position. The length of our pec muscles at the front can be problematic. So both from a how easy, oh sorry, let me just take a jumper off, because it's probably easier to see with a, oh no, that's no better. In terms of being able to get your shoulder back this way is very important to counter the amount that we're stuck forwards. Okay, and that's anybody sitting in a chair, as we were talking about before. It's also about what your head's doing relative to that. I tend to use, if you can't lie on a bed with your arms back here, flat on the bed, you probably need to think about doing something about your how long, you know, your pec major length as well. Now, I will put a proviso on that. If you haven't got fully innervated shoulders, you do need to be careful about being up in that range if you haven't got full control around your shoulders. The other one that tends to be a particularly big problem is the range at the back of your shoulder. Tends to be the one that also tends to get tight because of all the things that you're doing. Okay, I would probably also say that there's some movements or ranges of movements that you want to probably avoid. I think there was a question in the Q&A before about an overhead monkey bar.
Yeah, there are a few, and I was going to get onto them. I know we've only got you for about half an hour or so, Janet, so just going to look at if we can answer some of those questions. So there was that monkey bar question.
Yeah. So generally what we've found, as you know, because spinal injury units have, been around 50 or so years now, and we have definitely changed how we manage and what we teach people and that over time. What we have certainly discovered is overhead pulling in any shape or form, whether that's you getting into the car doing that, whether that's you using an overhead triangle, that definitely is not great for shoulders, repetitively doing overhead, trying to do that, because you're in a little bit more, there's more chances of things not working well in good timing up in that range. Your shoulders tend to be the strongest, sort of from 90 degrees down, in terms of where your shoulders are the most powerful and the most stable within that.
Thanks for that. Are you okay, Janet, if we just go through some of those questions? So someone asked what your thoughts are on managing distal clavicle
osteolysis.
Yeah,
that's probably a little bit beyond this one. Sorry. I probably would need to follow up with that person.
Next one, is the wrist also a common body part that is prone to injury as well?
Yes, very much so.
I think, yeah.
Very much so. So that's what you're doing in transfers, how you're having your hands in transfers and pushing. Carpal tunnel syndrome is a very, very common thing to happen in wheelchair users. How you use your hand for transfers can make a big impact on that. Generally, you don't want to be doing weight bearing through an open hand. You want to be fingers under if possible. If you've got the strength to be there and the surface is okay, then a fist. And you don't want to be trying to lift on your fingers either as well. So there are different push rims and that work better for some people. And, that can be how you're using your hand, but a lot of that needs to be assessed more individually on that.
And the carpal tunnel, Jenna, that's a cavity in the wrist where the nerves go through. Is that something?
So carpal tunnel, sorry, I haven't got a picture. You've got a row of bones that make a sort of semicircle, and then you've got a fibrous bridge over the top. In that hole, you've got nerves, tendons, and everything that go through here. So it's prone to swelling. Like if you get a little bit of swelling from irritation of any of those tendons or anything like that, it can swell up and compress the nerve. So that's where you get the pins and needles in your hands. Often that tends to happen at night. Again, can be quite treatable as well and be managed. So to seek advice, I think, is probably the strongest recommendation there. If you've got pain, please don't ignore it. Let's see what, be assessed and see what can be changed and what can be done to help manage it, rather than just living with it.
I think that's good advice, Janet. It's really important to, if you've got pain or issues, don't just sit and wait until things get worse, because the longer you leave things, the worse they can be, and the outcome could take a lot longer. Another question here, wondering about rotator cuff deep twingle at night in bed, but it's okay during the day. So
so generally, if you've got pain that's keeping you awake at night, or you're pretty good during the day and you're getting pain at night, it means you've got a bit of an inflammation process going on there. So you probably, it needs to probably be assessed and looked at, and looking at what you're doing during the day that's ended up that happening as well. Usually that's the one, night, trying to get rid of that night pain is, usually the first step of trying to manage your load and doing exercises and things to help that.
So again, advice there is to see your doctor or your physio.
So I'll touch at the end maybe in terms of where to go to get some help and assessment.
Okay. Because there was another question as well. If someone is looking to find a physio or see a physio, is it better to find someone who specialises in spinal cord injury? Any physio? Okay.
Yeah, so I think there's different stages, and it also depends on where you are and what you've got access to. I think you can certainly seek seek assessment and advice from a local physiotherapist. That may be enough if you're treating something relatively small. If it's recurring and if you're not getting anywhere, it might need to be looked at more globally as well. And I guess that's where I come in. It's where the spinal outreach service also come in terms of having a bit more of a global look at what your equipment, what your care is, what you like having a look at, I guess, the spinal aspect of that. And that doesn't necessarily have to be me assessing and treating you or them doing that. We can help other therapists that are more local to you in terms of providing advice and guidance on that front as well.
Good, thanks, Janet. So I think we might have just answered this question as well. So if you have a sore shoulder, is it better to go to the GP first or to the physio or try and see the spinal clinic?
Yeah.
I guess that's a spinal clinic that's part of the Austin.
I think my general answer there, it depends. Generally, I would probably, in terms of what a GP is able to do for you, is provide medication, I guess, scanning. You don't always need scanning though. And also they, in terms of the things that they're able to offer, it's probably going to be a referral to a specialist or a referral to a physio or something along those lines. So you don't need to go to a GP to go to a physio. You can, you can go straight to a physio to be seen. Yeah. There were probably a couple of other things. Are there any other?
Yeah, there was just a couple more. Our desktop hand pedal units, good for the shoulder.
Sorry, where was that?
A desktop hand pedal. So I think maybe a crack machine.
Okay. Yeah. So my general guidance on that is you want to be doing it below shoulder height. Okay. Generally, exercise-wise, you want to generally keep anything repetitive below shoulder height. You also, how our arms work is when we go to reach stuff and do bits and pieces, our thumb is up. Okay, so when you go, it's pretty rare that we end up in a turned in position. Our shoulders really don't like that, and they certainly don't like that doing in a repetitive way. You're more likely to run in problems up here if you turned in. So when you're reaching and doing bits and pieces, you generally want to keep your hands, we sort of think about thumbs up, I guess, when you're going through things. We want to be turning out, not turning in, because if you think about the posture that we all tend to end up in, is it's sort of round shouldered and down, and when you're pushing and lifting and things like that, you tend to end up turned in. So generally we're wanting to turn out, thumbs up, and exercise generally below shoulder height. Okay.
This question, Jenna, it's probably related to that one as well, but hand cycles, are they, so with hand cycles, I guess you're working above your shoulders, I think.
It depends on your setup with the hand cycle. Yeah. Most of them have got the handles are we're talking about on-road hand cycles here?
I think so.
Yeah. So I think you have to watch you shouldn't really end up too much, but you might be slightly above shoulder height on that. Depends if you're kneeling or sitting, which style of one you're using.
I think the main thing is if you're not feeling awkward about the movement that you're doing, you have to be as comfortable as you can be around whatever movement you're doing. And if you feel uncomfortable doing it, then you probably need to reassess it.
Yeah. posture is certainly very important, and your wheelchair setup. If you're finding that you're having to hold yourself up with your arms, you can't actually balance in your chair without holding yourself up, that does add quite a bit of load to your shoulders forever holding yourself up. So having good balance within your chair is a really important part of that as well.
Okay.
Because that has, if you have to hold yourself up to do anything, then that has an impact on how you're moving day to day.
Janet, is the golden rule, use it or lose it, an actual true saying?
Yes, I think, and I think that also comes in. It's probably not to the extent that that's meant, but if you do nothing for your shoulders, then you're probably more likely to end up doing something that ends up in shoulder discomfort than you are if you have been exercising and moving. Where I think that comes in particularly is if you're trying to do a sport or you're starting to do exercise, you're going to have more ability to cope with different loads if you've actually been doing some regular exercise previously. Okay, so if you've been doing some regular exercise, it's unlikely that you're going to get a change in load that is going to be significantly more than what you know where you're at. So where you run into the biggest problem is if you've done nothing and then you do something, you know, do quite a lot. Okay, so if you're going to go start doing some exercise or starting to try a sport or doing some dancing or something like that, it is really important. It's great to be doing all those things, but you do need to watch that you're not going from nothing to I'm doing an hour of this and expect not to be sore after you've done that. So it's the you need to gradually build yourself up into that. So probably the other bit that I haven't covered that much about is exercise. I'm not sure if you're wanting me to talk a little bit.
There was actually a question on exercise. Someone made a comment about overhead exercises should be avoided, but what exercise would be recommended for the shoulder and rotator cuff strength and health?
Yeah. So I can talk general principles here. Really, I think for me, the biggest thing is you can do a shoulder exercise really well, and you can also do a shoulder exercise really badly. And I'll try to talk you through a couple of principles to help you be able to gauge some of that. So one of the, I guess, things that I tend to talk about is, number one, do you have enough mobility? Do you have enough range to be doing that exercise and to be doing that movement? Because if you're right at the end of your range, you're much more likely to injure yourself or not have enough control. So for example, tricep exercises overhead can be a bit problematic because they're right at the end of your range, and if you haven't got the control to be there, that can be a little bit of a problem. So like I said before, knowing that you've got your pec range, across your chest range, and that you've got, if any exercise to take away is reversing your posture through your shoulder blades, is probably the number one exercise that most people can do. You can certainly now very carefully, please don't tip yourself out the back of your chairs, because as soon as you take your arms back, make sure you don't tip back. Yeah. But I generally tell people to pop their hands either by their wheels or towards the back of the wheels if you're in a power wheelchair, over the side of your things. And if you're in a power wheelchair, you might also need to add a little bit of tilt and bringing your shoulder blades back wide. Okay, so that should be a regular posture exercise that we do. Everybody should do during the day. Anybody who's sitting for prolonged periods, that's a really, really important one. where we run into trouble a little bit with shoulder blades, you remember before I spoke about how your shoulder blade has lots of muscles that are coming from it onto your shoulder? What that means is it's got two free ends, okay? So if your shoulder blade is not stable, then it's going to affect how everything moves, okay? So a really, really common exercise that people get given is rotating their arm out, okay, which can be a really, really good exercise, but it depends on what's happening with your shoulder blade. Okay, if you're here and you're rotating, that's not going to do your rotator cuff, you know, any good at all. It does depend on how stable you are and what you're doing with your shoulder blade. Okay, and it's the same with, yes, I can put a weight on my arm, but if I don't have the shoulder blade stability to be able to stabilize my shoulder blade while I'm doing that movement, then you've got to ask yourself what you're strengthening and what you're exercising. So the second thing I tend to talk about is stability. What is your stability? What's your shoulder blade stability like? And what is your shoulder blade posture like while you're doing something? They don't need to be fixed, but they do need to be in a better alignment for a better movement. Okay. The other part of stability is your trunk stable? For a lot of you, you might be able to do exercises on both arms at the same time, but some of you can't, because as soon as you start doing that, you start poking your head, or you're using other parts of your body to fix, that is then going to affect how you're moving. So you do need to think about, am I stable enough in my trunk? And if you're not, you might need to use props, belts, other bits and pieces to make you more stable while you're doing that. The third aspect of that is also then balance, which I guess I've spoken a little bit about in terms of that stability, but it's balance of exercise that you're doing. So unless you are not able to do a task, you probably don't need to work on the muscles of lifting, pushing, and all those type of things, because you're doing them every day. If you can still work on them, but you do need to make sure you've got a balance of what muscles you are working. It's really, really common to go into a gym, and if you are able to get on and off some of the equipment or that, the amount of machines that are there for your pecs is much more than is available for your back muscles. So you need to think about the balance and what muscles you're exercising and how many exercises you're doing of a very same or similar thing. Okay. You need to counterbalance all the pushing side of things that you're doing in your everyday life. So if you only do a couple of exercises, you really need to work the muscles at the back and also working on your rotator cuff. So yeah, you do need to think about the balance of what muscles am I using, which ones do I use every day, which ones do I need to do to, you know, to maintain me and keep on going. Yeah. If you are doing sports and overhead things and trying to exercise your rotator cuff to keep it strong, you do need to be quite specific about what range you're doing that in. Okay, so a rotator cuff exercise down here is not going to help you for badminton or tennis or something you're doing up here. If you're having to do an activity up here with your rotator cuff, you need to be able to do a rotator cuff exercise in the range that you are using it. It needs to be quite specific to what you're trying to achieve. So I usually try to say to people with exercise, well, what is your goal? What are you trying to gain out of doing the exercise? Are you trying to get strength to do an activity? Are you trying to maintain your shoulder balance and health? Are you trying to prepare for a sport or an activity? Or are you just trying to keep fit? So what you're doing really needs to be quite tailored towards that.
Great advice. Thanks, Janet. One thing, or actually, someone asked, if they're looking to find a physio, are there any physios that do home visits? I think I can answer that. I think there are some that do home visits.
Yes, yeah. Depends where you are, what your funding source is, etc., etc. If you're needing a good overview and in terms of equipment and other bits and pieces, sometimes that does need to be done at home.
Yeah. And if someone asks to specifically get in touch with you, is that possible? So this person has had shoulder issues and has been trying to deal with it for the last 14 months. And they've tried different things.
Yeah.
I'm guessing they want to just pick your brain, I guess, what their next options are.
Yeah, no, that's fine. I'm part of the Victorian Spinal Cord Service, so obviously I generally see Victorian Spinal Cord Service clients, but that doesn't mean I can't offer advice to other therapists and that helping to manage that. And I am also, there's more than just me. As I said, there's we do a fair bit of work with people aging and shoulder issues as people are aging as well. And that's really where teams like the Spinal Outreach team, are very, very valuable. You can also get advice from, probably neuro physiotherapists with a neurology background, and a lot of you will be NDIS funded. And there's certainly groups that have both occupational and physiotherapy. I think when you're having to look at the broader equipment side of things, you do need more than just a physio. I think you need a team to be helping out there.
Oh, excellent advice, Janet. You've given us so much information. I'm not sure. So do we have you for another 10 minutes or so?
Yes, I'm all good. I'm at home, so it's a bit easier for me to do the school pickup. So it's only 10 minutes down the road as opposed to half an hour.
Good. So I think we've covered the questions that have come through at the moment. This next question, I might throw to Duke. So is there a recommended stretch routine? And probably all of us could input into this as well. Duke, just wanted for you to speak us through your stretching routine before you start your sport. So there is a regular stretching program that you do with you.
Yes, there is, very much so. Very much as Janet has just said, look, you've got to do things in moderation. And what happens is if, as Janet is saying, it's to do with the load, right? So I specifically play a sport, which is para-badminton, which means that my arm is, I have an extended arm above my shoulder. And what I need to do is specific exercises and particularly warm up. I normally play for about 1.5 hours, 2 hours of para-badminton. And from that, I need at least a 20-minute warm up. And that's with a TheraBand lifting my playing arm up above where I'd probably be playing a high backward shot. I imagine it'd be the same for tennis, but it's to do with actually, I suppose, Janet, is what you're saying is gently letting your body know that it's going to go through some sort of energetic exercise and not be in shock. Because I think since I've been doing proper warm-ups, I've found that my body is really ready to receive something that's really stressful. And a lot of the approach, and I'm not sure whether, Janet, you mentioned this, and that's the psychological side of it. Not only you got to think about the physical side of it, but you've got to be psychologically prepared to adapt to what's happening around you. And that can actually reduce, I think, stress. And stress makes you do strange things that you probably wouldn't have done in the past. So, as you say, Naz, doing...
Yeah, actually, Duke, I was going to get you to maybe demonstrate what your stretching program is. You know, you said it takes 20 minutes or something like that. I'm guessing most of that would be pushing your chair, forwards and backwards and all that sort of stuff.
And
But regarding rotation of your arms, do you rotate your arms sort of around and stuff like that? If you can just talk us through some of that, would be really good.
Well, I really need my TheraBand, and my TheraBand, unfortunately, is in my sports bag, which is down in the garage. But what I do is I try and create it's a moderate sort of like movement there to get the arm taking the strength. So I'm not sure whether you can see that or not.
Yeah.
I'll just back out of the room a little bit, open up some doors. Janet actually gave me some really interesting exercises, and that is sort of like not to raise my shoulders up and use my neck muscles, but lower my shoulders down and rotate forwards and backwards so that I'm using my pecs.
No, it's the other opposite.
Opposite, sorry,
yeah.
Using my chest and my back plate. And it's a matter of not doing, because when we push it, we tend to do this. The idea is to actually rotate that way. And since I've been doing that, thanks to Janet's advice, I really have better improvement. My right shoulder is almost as good as before. And I've got to tell you, there was a big question as to whether I should, because I fell out of my chair and landed on my right arm. This is when Janet was helping me a year ago. The question was, do you want to get a surgery done? And Alex is a very brave man. He actually got it done. I was a bit of a chicken. So I sort of like said, okay, I'll try and do things without the surgery, because it would have meant, and I'm sure Alex can sort of like give more about that, he was out for not as long as what they were telling me. They said 6 weeks for the operation, where they attach your arm to your body so you can't move your arm or your shoulder.
Yeah, I was going to get them.
Yeah, it'd be very good to, yeah.
And then, sorry?
12 weeks.
No, I was going to get Alex to run through that. So I'm saving Alex to the last. So
sorry. I was stealing your thunder, Alex. Sorry.
I wanted him to run through pretty much how it all started. But no, you continue, Duke, but just wanted to make you aware of that.
Yeah. And so really, it's to do with what workload. Now, particularly when you're pushing a wheelchair on a court, there's explosive times where you need to move to the front and the back, but there's not always explosive time. So there's this thing, I'm not sure what it's called, muscle memory or something, but it's reaction times and watching what your opponent's doing and I don't know, having a sense to move before he's actually even played his opposing shot. And so there's the thing in pushing the chair, which is a totally different action that once, when you're in your sports chair, you've got to hold the racket and propel yourself backwards and forwards. And so there's a whole different sort of gripping routine between one arm and the other in being able to manage your movement on the court as opposed to your movement with your racket. And so very specifically, the stretching exercises are with a TheraBand, pulling it up this way, putting one behind your back and pushing that way. And then with TheraBands on either side of the chair, exercising that way, as I say, keeping your shoulders down, not lifting them up and using your neck muscles.
No, that's good. Thanks very much, Duke. So there are TheraBand warm-ups you could use, warm-ups using TheraBands, but even without TheraBands, there's stretches you could be doing as well. And I think this is something, if people are interested in knowing what that would look like, and get in touch with us later on, and maybe there's something, there will be something we should be able to share around regarding that as well.
Yeah, I use the word TheraBand, but for people that don't know what a TheraBand is, it's a rubberized band of different intensities of strength, which allows you to have resistance to your arm movement.
No, good. Thanks, Duke, Janet, sorry, you going to say something?
I was just going to say, I think there's two different things here in terms of, I think there's doing a bit of movement before you start doing sport, which I think is what Duke is really talking about there. And there's also making sure that if you are starting to do something, that you gradually go into it, that you've done some preparation and I guess grading up in terms of the amount of activity that you are doing, so that you don't end up getting sore or injuring yourself as you start to do things. So I think they're two separate things.
Good. So just wondering, was anyone wanting to make a comment on any of that? Emily, or Lynn, or Geoff?
I was going to add that probably my favourite exercise for my shoulder, and I get a cardiac workout at the same time, is when I swim, I tend to do backstroke. And I've found that to be really useful and have missed it while COVID's been on and the pools have been closed.
Thanks, Lynn. We've got someone here, Sal, I'm not sure if you can hear us. Someone mentioned they want to ask us a question, so not by text. I think they want to...
yeah, somebody's got their hand up.
And do that. So that's okay if we do that?
Yeah, I've just set Duke Pradeep.
Oh, Pradeep wants to ask a question.
Talk. So if Duke, if you it's not working very well, Pradeep.
Sorry, I couldn't hear.
Did you want to ask a question, Pradeep?
Yeah. No, I'm okay.
Oh, well, you had your hand up. All right, no worries. We'll move on.
Oh, that's we must have answered it, so that's good. I think we're doing well. I'm just having a look if there's any other questions. If no one wants to add anything, I just want to move on to, talking about, question marks around surgery. I know Duke, for example, he talked about it a little bit before, but he had a pretty serious shoulder injury, which has recovered over time, so a lot of these situations, Janet, surgery is a last case resort, would you say? So if someone's got an injury, they need to take some steps to see what else they can do to improve the situation before surgery.
Yeah, I mean, surgeries, in the general population, as I said before, there, 5-year rates, surgery versus exercise, there's not much difference. So it's certainly not second best treatment to be managing it through exercise and environment modification and other bits and pieces. I think making sure that you have tried and looked at other things that you can change and modify, and looking at being assessed physio, OT, by the general team in terms of what's happening, because to see whether it can be managed conservatively, because if you're a wheelchair user and you are not using a hoist regularly, then surgery it's pretty big. There's a lot of things to consider, and I'm sure the panel members can attest to the amount of change and effort and things that takes. It doesn't mean that that's not an option, but it's a pretty big step.
Yeah, very good. Thanks, Janet. Someone said, can Duke please do that exercise again? Now, I'm not sure which exercise they were talking about. So you've got a special request there, Duke. So while you're doing that,
I was doing two different sorts of exercise.
Okay, if you can quickly show that off again, I think.
It's using a TheraBand. Hang on, see if I've got something that I can use.
So yeah, Janet, you're saying using TheraBand and well, not TheraBand. So the purpose of that is for, well, there are two different reasons why you would do that, isn't there?
Yeah, and I think you do probably need to be careful adding TheraBand to that movement if you haven't done other stuff before, because like I was saying before, you do need to watch out what's happening with your shoulder blades. Just adding TheraBand and weights to things doesn't necessarily, often you need to be able to get good movement quality without resistance first before you start adding resistance. And you need to, when you are adding resistance, you really need some feedback about what's going on and whether or not you've got a good movement pattern or not.
Yeah, I didn't do the TheraBand just off by someone suggesting it. It was the TheraBand was given to me by a physiotherapist, and he gave me very specific things and different grades of TheraBand to use. But that, as you say, Janet, that wasn't my first step. The first step was actually just static movement on my arm and things like that. And it's an evolution process in the repair thing. You can't just sort of like say, well, you can do this and repair it. You got to do things in moderation and manage the change, and that's why it's very important. He uses that almost like what I call a projector to see how much my arm was changing with specific exercises that he was giving me, and that allowed him to manage what type of TheraBand I was using and the actual movement itself. So that was the exercise, was the arm up. And then the other one was, I'll probably need to be forward here, and correct me if I'm wrong, Janet, but it was like keeping your shoulders down and pulling them back.
Just a general wide collarbones across the chest,
exactly.
Which was the reversal exercise that I was talking about before.
Yeah, and that really helped in two things. And one was the pain management. As when I was sleeping, I was having a lot of pain in my shoulders. That seemed to really help because I was sleeping on my, I have to sleep on my back because I use a CPAP machine. But when I sort of like went onto the shoulder that was sore, that woke me up. And so being able to manage that a little bit better and reduce that pain threshold was very important for me to get sleep and rest. And then there was the other exercise when you're in a manual wheelchair. I use a manual wheelchair and a manual sports chair, of course, is that it's the impact of actually pushing and using your trunk in a way to give enough inertia to move your chair a bit more, rather than just using your shoulders as to give you momentum.
Excellent, thanks.
Does that answer their question?
Well, I think so. I'll get back to us if it hasn't. I'm just having a look now. Yeah, okay, so just positive feedback. So definitely interested in suggested stretching routines, which is good. So I want to talk to both you, Duke, and Alex, but more Alex. So you had a recent shoulder injury, which, I think you were quite seriously looking at getting surgery done. Now that improved over time. So I think, I know the message there is when you have a shoulder injury, don't just assume the worst. Give it time and physio and all that sort of stuff and see how it's going to prepare, because more often than not, the shoulder injury will get better. But in some circumstances, and this is where I want to bring Alex into it, where surgery is the only option. Once you've looked at physio and had cortisone injections and whatever else and given the time. Alex, so you recently had shoulder surgery, and again, you tried different things along the way. So you didn't just say, I've got a sore shoulder or you have to have surgery. So you looked at different things to fix the issue up. So I'm going to ask you a few questions, and please anyone jump in with their own questions as well if you want to. When and how did you hurt your shoulder? Is that the first question?
Yeah, well, I started having trouble with my shoulder, my left shoulder, in 2004. And then I was on the waiting list for, I had a torn tendon, and so they offered me surgery, but because of my family, the kid was small, so I need to be at home, so I just reject the surgery. And then I keep working, and then I damaged my right shoulder because I was compensating the damage on my left shoulder. And then another 10 years later, they told me they had 2 torn tendons, so they have to fix the good one.
So when you said they, Alex, do you mean, did you see physio first or see the doctor? And you know,
yeah, I went to see the GP. Then I have I went to the Austin, and I have see MRI scan, and they told me they need surgery on my 2 shoulders. And then they say, you know, you have to do, we'll do the first one that is not that bad, and then we'll do the other one that is really bad later. So I just had my shoulder surgery on my right shoulder on 2017. And then I have to stay for nearly 4 months at hospital to be looked after. In state, you know, my shoulder, my arm in the sling for 12 weeks. And after then, we start doing exercises, and the exercises are they're very intensive because it's a lot of pain, because after having your arm immobilized, you know, for 12 weeks, you just get very stiff. But then it becomes fine.
yeah.
After 6 weeks of 4 weeks, you know, exercise in hospital, and then when I start doing on the 12 weeks, because I'm being para, so I have to rely on people just to get dressed, to get hoisted into bed, into the, you know, commode, into the shower. So I have to be dependent into people, but I knew that I have to do it. So I just did it, you know.
Yeah. So when you went to I'm just trying to let the others know out there as in the process. So you went to a doctor, and the doctor said try some physio first, or they say it's pretty bad, we need to do some surgery.
No, I did exercises, physio. I had some injections, and did work for 2-3 years. And then the pain start again, another cortisone, and keeping going for another. I keep going for 14 years with the damaged shoulder.
Well, okay.
And so at the end, they told me, you know, because I postponed putting him back, you know, not to have the surgery. The damage was very greater, and my shoulder was beyond repair. So it was no cure. No surgery that was going to be mended it.
Okay. So do you know where the most damage was? I mean, this is probably going to be a technical name for a muscle.
It was the rotary calf tendon, and because it was 4 centimeter gap in the tendon, so they told me the tendon wasn't able to be, because after 10 years, 14 years, the tendon was probably a little bit stiff, so wasn't going to be able to stretch and reattach it into my shoulder.
You've totally ruptured it.
Yeah. So, and so I have all the tests, you know, I was able to move my arm up, all my ranges, no problem. And so the surgeon, before I just went to theater, he said, you know, can you do this, all the movement? And he said, you know, it's amazing that you still got all the movement, even with the torn tendon, if for you to have a frozen shoulder and not be able to move your shoulder or your arm. And so he said, well, you know, we'll go into theater, we'll do a cleanup into your shoulder. And after the surgery, he said, you know, we were able to fix it. So you got a fixed shoulder. Your tendon was able to stretch and reattach it. So
no, that's great, Alex. So just want to let people know out there that the reason you went to have the surgery, I mean, again, it was a last resort, and you never lost any function. So what happened is other muscles compensated for your range of movement. And the main reason you went for the surgery is because of pain. You just had lots of pain.
The pain was variable. It was intense. I have numb scalp, numb shoulder, sore chest, sore back, so numb fingers at night. So it was really, the pain was really intensive. It's why I had the surgery, because there was no other options. The cortisone was just, it helped, but then I have to have anti-inflammatory pills just to reduce the inflammation. But at the end, I knew the only solution was the surgery. So I had to.
And even the surgery, it's not guaranteed as well, Alex, isn't it? So when they say you need to have surgery, I mean, nothing's guaranteed that it's going to fix the problem.
Well, it was guaranteed they was going to fix the problem.
The pain,
but with my left shoulder, they said they wasn't guaranteed they was going to work. And so it's what they say, you know, if I went to theater and they said if you can't mend it, we just put him back as it was, because we don't want you to be worse off, you know. But they were able to fix it, so it was great. You know, it was good news for me.
Bonus for sure, yeah. Because they actually ended up repairing your rotator cuff as well as getting rid of that pain.
Yeah. And so 2 years later, they have 2019, I'm at my left shoulder, and no pain, no injection, nothing. So it's just the only thing they have to do the exercises, and I used to do exercises all the time with a pulley just to start lifting my arm, you know, because I couldn't even touch my shoulder, my chin.
Oh, that was after surgery, yeah. I wanted to ask you about that too, but just wondering, has anyone got any questions or comments before we continue?
I'm probably going to have to go, Naz.
Okay.
Yeah. One thing I would just say is if you are needing to contemplate surgery, if that's where you are in your journey, and you're make sure that you're touching base with the spinal outreach if you're a Victorian Spinal Cord Service client or equivalent, to make sure that you're planning in terms of stuff that you need in terms of hoisting and equipment and bits and pieces like that, so that you're doing all that planning before you have the surgery, because it's not, that's not necessarily automatically done.
Yeah, that's right. That's good advice, because it doesn't just happen. And when it does happen, you need to put things into place. Just like Alex said, he was dependent for so many months with, hoisting and dressing, and showering and bowel, bladder, all that sort of stuff. Yeah, so that's really important.
Excellent.
It was nearly 4 months in I
Yeah.
studied at the
So I wanted to get a bit of a timeline from you, Alex. Janet,
I'll
if you've
say
got to
good-
go. can you-
Yeah, I've got to go.
Yeah.
Okay.
Janet, thanks so much
Thank you,
for
Janet.
joining us and answering those questions and giving us that information, because, yeah, really important, and really appreciate your time.
No problem.
And if anyone wants to get in touch with you, we'll, as you mentioned, just through the spinal cord spinal
Service, yeah.
service, and
Yeah.
they can get in touch with
Yeah,
you or
beautiful.
one of the other physios.
Okay, thanks a lot.
Thanks again,
Janet.
Janet.
Bye.
Thanks.
Alex, sorry, I just wanted to be more specific with your surgery thing. So,
Naz, can I ask a question of Alex?
yeah, sure.
Alex, once you had the operation, the first one, and your arm was in a sling, how did you sleep?
Still.
Yeah.
Well, the nurses used to come, twice a night, to give me help me to roll over, put a lot of pillows behind my back, under my legs, between my legs, and yeah, so I didn't have trouble, sleeping, because you're conscious about, not moving, and told not to move your arm, and because every little movement in your arm hurts, because I was lucky that my surgery didn't hurt a lot, but other people suffer more pain than I did. But yeah, so it's just yeah, there was no problem sleeping at night.
Okay. Is that because you were well and truly disciplined not to move?
Yeah, exactly. Because the surgeon told me, if I do any quick movement on my arm, if I just do that, I could damage the tendon again. And if I do that, they wasn't going to be able to repair it, because they say it's just better just to be still and just keep
Yeah.
your arm.
You can't muck around with it. I'm sorry, I just wanted to interrupt. Emily's going to have to leave us as well. Emily, thanks so much for joining us as well. Really appreciate it. Did you want to leave us with any comments? Sorry, you're on mute, Emily.
Bye. And my last bit is when you're doing exercises, make sure you're doing them correctly.
Yeah.
See ya.
Yeah.
No worries. Thanks again, Emily.
Emily.
All right, so just on to, if anyone's got any questions, please just throw them in there. But wanted to give people a timeline. So I've got a few questions here, and I know, Duke, you mentioned some of it as well. So when did you have your surgery, Alex? So
When?
yeah, when did you have your surgery? So I'm just trying to get a bit of a timeline on what that looked like for you.
The first one, it was on.
Or just say the latest one, the most recent one.
There was August 2019.
August 2019, okay. How long did you have to stay in a sling for? So no movement allowed at all. And I know you said this, but if you can repeat that.
Well, it's 12 weeks.
12 weeks in a sling with no movement at all.
Yeah, only the only exercise that you're allowed to do is just moving your fingers.
Just your fingers, okay. How many weeks after surgery did you start your physio? So start a bit of movement. So I'm guessing 4 weeks after the surgery, after the sling came off.
After the sling came off, we just start doing it was the 12 weeks, mark. I just went to see the surgeon. And then you say, you start doing exercises 2-3 days after. I start doing exercise 5 days after the sling come off.
Okay.
And
very, very light movement, wouldn't it?
very light.
Yeah.
Because you can't even touch your chin. Because your arm been still for 12 weeks. So you lose all the muscles in your arm.
So you lose all your strength. So you've got to build up that strength. So after 12 weeks, how many weeks after? Well, I mean, you've probably answered this as well. How many weeks after surgery did you start physio? So that's 12 weeks.
After 12 weeks, and I stayed there 19 weeks, nearly 19 weeks.
19 weeks.
At the Austin.
Oh, you had the Austin for 19 weeks?
Yeah.
Was that in total or after the 12?
Total.
In total. Okay. And when were you allowed to do supported transfers?
I was just doing the sliding board first, because then it's just you feel your body is just so heavy, so sliding boards.
So how long after the surgery was that? I'm just trying to let people know how much support you need after surgery. So first 12 weeks was in a sling, then a further 3 months of limited physio, light physio.
No, it was so it's just 12 weeks, and I stayed there until at the end of November. Yeah. So it was just it's another 5 weeks. So it's another
5 weeks after the sling came off.
The sling came off.
And you were able to do assisted transfers.
Yeah.
Okay.
And then but I started doing physio twice a day. So I just do it all physio and exercise it by myself as well.
Yeah.
Because I did want to get better, quicker. And so it was part of my that I did want to get better, in having my muscle back. So doing the exercises and those pulleys just to start lifting your arm. Because after a week of exercises, it's just be able to lift your arm, and then and then you have to demonstrate that you're able to be able to transfer from the chair to bed, and vice versa. And after they're doing the assessment, said, okay, you can go home. But before then, and then I just have to transfer into my car. And then you have to do it then, and so they assess you too, and if you're able to do then, you're able to go home.
So pretty much from surgery to getting your independence back and getting the all clear, how many months do you think went by? Was it 6 months, 8 months, 12 months?
No, I was just I was driving in December. I started my surgery was on the 2nd of August, and then December, 5 months later, I was just driving.
So 4 months later, pretty much.
5 months, yeah.
Okay. Good. Thanks very much, Alex.